Okay, so let's talk about some colon problems. Large intestine, colon, or large bowel, they all mean the same thing. So inflammatory bowel diseases. Okay, I mean, we can talk about inflammatory bowel disease. There's so much information on them, but let's stick to the really core information. So Crohn's disease. So there's two inflammatory bowel diseases: Crohn's disease and ulcerative colitis. None others. Irritable bowel is not inflammatory bowel disease. Gastritis and all those other ones, no, it's these two. Okay, so Crohn's disease is basically, so they're both autoimmune, by the way. We don't know the cause. We think they're autoimmune diseases. So the body's attack on its own gastrointestinal tract. Crohn's disease can occur anywhere from your mouth to your anus. Okay, and in the mouth you can get oral ulcers. You can get stomatitis, you can get esophageal ulcers, you can get inflammatory lesions in the small bowel, in the small intestine, and they're full thickness. They go right through the entire thickness of the wall, wherever it's affecting. Okay, so if it's in the small intestine, you could have multiple areas of patches of Crohn's disease. Same thing in the large intestine. Crohn's also goes through the large intestine. You can get Crohn's colitis with these full thickness patches of inflammation. Okay, there's no cure for Crohn's. It's a mouth to anus disease. We usually treat it with corticosteroids to settle down that inflammation, and then we typically use medications to suppress the immune system. A very common one would be azathioprine. I don't know if you've gotten to there in pharmacology, but azathioprine basically suppresses your own immune system to stop attacking the bowel. Okay? So you can just imagine that Crohn's disease can cause significant malabsorption. If it's really affecting the small intestine a lot, then all the patchy areas of inflammation aren't going to be doing any absorption. So you will have malabsorption of nutrients. So patients with Crohn's disease often have weight loss, diarrhea, steatorrhea, fatty stools. They often have abdominal pain. They're vitamin deficient. Let's compare that to ulcerative colitis, which is only in the colon. It's nowhere else in the bowel, in the gastrointestinal tract. And it's superficial. So it's superficial inflammation of the colon. So are you going to get diarrhea with that as well? Sure. Actually, you get more diarrhea with ulcerative colitis because you're not absorbing fluid from the large intestine. Can you get bleeding with it from the inflammation? Absolutely. Diarrhea, so bloody diarrhea, very common. Can you get weight loss and abdominal pain from all the fluid you're losing? Absolutely. Fevers from the inflammation and fatigue. But remember, it doesn't go anywhere else. So you don't have a malabsorption syndrome of nutrients. You don't typically have vitamin deficiencies. So they're different. Now we still use corticosteroids to settle down ulcerative colitis, and we often use immune suppressants such as azathioprine to settle down the immune system from attacking the colon. And remember, if you have chronic inflammation from either Crohn's or ulcerative colitis in your colon, you are at higher risk for colon cancer, okay? Because you have chronic inflammation, and it's the same idea anywhere else. If you have chronic turnover of cells that are being destroyed, you're more at risk for developing cancer there. There is a cure for ulcerative colitis. You can have your entire colon removed. And if you have a total colectomy, then there is no colon to be affected. So, and ulcerative colitis doesn't go anywhere else. So total colectomy is curative for ulcerative colitis. Okay, so Crohn's disease, this slide. So there's family genetics to these inflammatory bowel conditions, Crohn's and ulcerative colitis. Look at the ages, 15 to 40. That would be for both as well, Crohn's and ulcerative colitis. Autoimmune factors, we think so. Now let's just look at the other symptoms. So nausea and vomiting. Yeah, Crohn's can affect anywhere. You can actually, because it's a full thickness of the bowel wall, you can get obstructions, small intestinal obstructions, because there's so much swelling. You wouldn't get a bowel obstruction from ulcerative colitis. So nausea and vomiting with Crohn's disease, abdominal pain and distension. Distension definitely if you have a bowel obstruction because of all the edema from the full thickness inflammation. Often you get Crohn's in the distal ileum, and so that's why you get tenderness in the right lower quadrant, because that's where the distal ileum is. You can have tremendous amounts of diarrhea because you're not absorbing nutrients. Low-grade fevers, fatty stools, steatorrhea, because you're not absorbing your nutrients, so severe malabsorption, and you're also not absorbing your bile salts. So your bile salts are secreted by the liver, by the biliary tree, and they're reabsorbed in the distal ileum, most of them. So you can imagine if you have Crohn's disease in your distal ileum, which is the most common location to have it, you're not absorbing bile salts. So if you're not absorbing bile salts, and bile is involved in helping you absorb your fat-soluble vitamins, well, you're not absorbing fat-soluble vitamins now either. So you can become not only severely malnourished because you're not absorbing nutrients, but you're now not absorbing B12 from your distal ileum. You're not absorbing fat-soluble vitamins at your distal ileum. Okay. Later signs and symptoms: weight loss for sure, dehydration, electrolyte imbalances, anemia, any of those, because you're not absorbing your nutrients. All of those will happen. The weight loss, the dehydration, the electrolyte imbalance, because it's being just flushed into the colon without being absorbed. Why the anemia? Well, you're not absorbing nutrients that are needed to make red blood cells. You're not absorbing vitamin B12 from your distal ileum. So there's two reasons right there why you will become anemic. Also, you may not be absorbing your folate, which is needed for red blood cell production. Complications: so intra-abdominal abscesses, fistulas, peritonitis, deficiency in fat-soluble vitamins. So remember I said that in Crohn's disease, it's a full thickness disease. It's a full thickness of the lumen of the bowel wall. So because of that, it weakens the bowel wall, and you can get small micro perforations through the bowel wall in the small intestine or the large intestine, and then you can get small little abscesses forming around the bowel wall. You can get peritonitis if it's a full thickness hole where you're just leaking into the peritoneal cavity. Fistulas are really interesting. That's where the bowel, because it's inflamed right through the whole bowel wall, attaches to somewhere else and then forms a tunnel to where it attached to. So for example, your small bowel could attach to the vagina, and you would have an enteric vaginal fistula. And patients will come in saying, I have stool coming out of my vagina. If it attaches to your bladder, you could have stool when you urinate. If it attaches to the inner abdominal wall, you could have stool leaking out of the skin of your, from a hole in your abdominal wall, like on your front of your abdomen. So those are fistulas, okay, and they're really nasty. They're really upsetting to people, obviously. Deficiency in fat-soluble vitamins we spoke about. That's where the malabsorption of your bile acids in the distal ileum aren't occurring, because a lot of people have distal ileum Crohn's disease, and you don't absorb your fat-soluble vitamins. Okay, so this chart should make quite a bit of sense. Know the difference. So ulcerative colitis only affects the large intestine. It's a superficial inflammation of the large intestine. Develops in the rectum, and it doesn't have patchy lesions and normal lesions. It just migrates up to the rest of the colon and causes inflammation. So develops in the rectum and colon. So you can have a very mild ulcerative colitis in the bottom part of your colon, or it could involve your entire colon, which is called pancolitis. And it presents in a continuous pattern of inflammation. It's not patchy like Crohn's disease. It's all connected, the inflammation, only in the colon, remember. Inflammation takes place in the innermost lining of the large intestine, okay? 30% of those in remission will relapse in the next year. So it settles down with treatment, it comes back. Settles down with treatment and comes back. And that's normal for both of them, okay? Crohn's disease can present anywhere in the gastrointestinal tract, from the mouth to the anus, okay? Appears more commonly at the end of the small intestine. That's the distal ileum, where distal ileum disease will affect your absorption of B12, fat-soluble vitamins, bile salts. So there are some, it's important to know that that's where, and actually it can also fool us. People come in with right lower quadrant pain, and we might think that it's either an ovarian cyst or it's an appendicitis. It ends up being their first presentation of Crohn's disease sometimes, okay? Can appear in patches. You can get patches throughout your small intestine, patches in your large intestine. You might have some ulcers in your mouth, okay? Extends through the entire thickness of the bowel wall, and that's where you can get into trouble with a bowel perforation, little tiny abscesses forming on the other side of the wall, because the whole thickness of the bowel is involved. Fistulas connecting to the vagina, the bladder, the skin, the abdominal wall, okay? 67% of those in remission will have at least one relapse in the next 5 years. So even if you're treated with medication, there's a very good chance that you're going to have a relapse. 2/3 of people will relapse in the next 5 years. The good news about Crohn's disease is there's much less surgery performed. We used to cut out pieces of patients' small bowels for Crohn's disease. And they would get to the point where they just had short bowel syndrome. And with the newer treatments available, surgery for Crohn's disease is much less common, which is a good thing. Okay, what about colon cancer? So what are the risk factors for colon cancer? So any inflammation of the bowel, of the colon itself, chronically, will lead to colon cancer. So ulcerative colitis, or even, as well if you have Crohn's colitis, both of them will lead to potentially colon cancer 20, 30, 40 years down the road because of chronic inflammation. Older people are at risk for colon cancer. Most of us, so one of the recommendations in some states and in Canada is that we have a screening colonoscopy at the age of 50 to see if we have polyps in our bowel, or if we're developing an early colon cancer. Other places offer that a fecal occult blood testing, where you put some stool on the piece of paper and we test to see if there's any blood in it. Definitely not as accurate as a colonoscopy though. Family history. So if you have brothers or sisters or family members that had colon cancer at an early age, that would put you at higher risk. North American diets, high in fat, low in fiber. Fat causes more secretion of bile. Bile is harsh on the colon wall. It causes a low-grade inflammation and predisposes people to colon cancer. Okay, so a high fat, a high animal fat diet, low fiber diet, increased risk for colon cancer. If you have colon polyps, you may not know this until you have a colonoscopy later, but maybe you have some polyps. And polyps are really benign at the beginning. As they get bigger and bigger, 3 centimeters, 4 centimeters, 6 centimeters, they develop cancerous parts of the polyp. And that's where we think most colon cancer comes from colon polyps. There's a genetic condition called familial polyposis, where there's hundreds and hundreds of polyps in the colon. So these people are at risk for developing colon cancer from one of those polyps. Obesity, smoking, and inactive lifestyle. Those are links to colon cancer. I can't tell you exactly why obesity, smoking, and inactive lifestyle are risk factors. They've just been studied and they've been linked to colon cancer. Okay, so let's talk about colorectal cancer screening. Okay, so colon cancer is common enough that there's screening guidelines set up. Okay, so let's just talk about a couple of them. So say between the age of 45 to 75, on the left there, what kind of screening could someone have? And in many places in the United States, there's just a suggested screening for colon cancer at the age of 50. Okay, because most cancers of the colon don't develop when you're 20 or 30. They're typically as you're approaching 50. Okay, because it takes time for a polyp in the colon to grow, and then a larger polyp to then become and develop cancerous changes. Okay. So there's an assortment of screening tests, some better than others. So the first one we can talk about is occult blood screening, or that guaiac test that I mentioned before. So somebody goes home with a kit, they collect a bit of stool, they apply the stool onto that little paper slide that they're given, they close it up and bring it back to the lab, and the lab applies some solution to it to see if there's any blood. Okay? If there's blood, that doesn't mean you have colon cancer. It just means you have blood in your stool. And now you have to go on to a more specific test to see if you actually have colon cancer. So really, it's a pretty basic screening test. It can be used, but it's just a screening test. Now, if it's negative, does it mean you don't have colon cancer? No, it just means that on that particular day, you didn't have any bleeding when you put the stool on the tester. Okay, so it's not a terribly accurate test, but for thousands and thousands or millions and millions of people, it will pick up some colon cancers by the very fact that some colon cancers are bleeding on that day, and they'll go on to have a more specific test. But it's not totally reassuring, because some colon cancers aren't leaking blood on that day, so the test is going to be negative. Okay. So what do they need to do if they have a positive test? Well, if there's a positive test, they have to go on and have a colonoscopy, okay, which requires a full prep. You have to completely purge yourself of any stool in your colon with these different tests, such as, or these different solutions, such as Go Lightly, which is a very odd name for drinking 4 liters of a purging liquid. And the colon has to be completely clear of stool, so that when they put the colonoscope into the rectum, they can view the entire colon and its wall to see if there's any abnormalities on the wall of the colon. Okay? If the prep wasn't taken properly, then there'll still be stool in the colon and the test won't be accurate. So they'll stop it and rebook it for another day. Okay? What's another option? Well, instead of having the occult blood testing and to see if there's any blood in it, a lot of people at around the age of 50 just go and have a colonoscopy. So it's not that they have symptoms, they're having a screening colonoscopy to see if there's any polyps or if there's any cancers in the colon. Okay? Because often there's no way of knowing if someone has a colon cancer until it's too late, until the colon cancer has spread to distant areas. Okay, so those are the 2 screening tests: the occult blood screening test that you bring back to the lab, or just setting up for a colonoscopy and having the entire colon viewed with a camera. Okay. Now, I just want to mention that if someone has a history of, say, ulcerative colitis since childhood, that's a totally different discussion, because those patients are at risk for developing cancer at a much earlier age, because they have this inflammatory condition in their colon that can lead to cancerous changes. Patients with ulcerative colitis often need a colonoscope every 5 to 10 years at least, okay, screening for the potential for colon cancer. Okay, so this is just average screening advice for a typical man or a woman. Okay, and as we get to the age of 80 or 85, then it becomes questionable whether there's any benefit to continue the screening program, because at a certain age we end up dying of other conditions, and there's very little value in continuing the screening at an old age. Okay? And the other issue that occurs is if you have an occult blood positive screening test, or you go for a colonoscopy, well, the colonoscopy has a chance of perforating your bowel, right? It's not a big chance, it's about 1 in 1,000. But if you're 85 years old, you have a pretty thin colon wall, and the chances of perforating are likely a bit higher. So we tend to stop the screening over the age of about 80 to 85. Okay, and lastly, if somebody comes in and says, well, I had a bit of bleeding from my rectum, well, that's totally different. That's not a screening test anymore. We're not using an occult blood screening for stool, or we're not screening with a colonoscopy. We're actually going to set that patient up for a colonoscopy to look to see if the bleeding was from colon cancer or another cause, right? So screening is typically for asymptomatic people, and we're screening large populations for a certain condition.